Good morning, afternoon, everybody. So it's my pleasure today to introduce Dr. Dugald Seely, a naturopathic doctor, friend and colleague of mine for many years, and Dugald is the executive director at the Ottawa Integrative Cancer Centre. He is also executive director of research at the Canadian College of Naturopathic Medicine. Dr. Seely has a long career working in research here at CCNM and specifically in cancer research and cancer care. And the Ottawa Integrative Cancer Centre was his, I believe, design and inception, and he has led it over the years to be a premier destination for naturopathic and complementary care around cancer and its effects for people. He's also the founder and president of the OICC Foundation, which is a charitable organization that supports the Ottawa Integrative Cancer Centre. And also, in last year, in 2017, he was awarded the Dr. Rogers Prize for Excellence in Complementary and Alternative Medicine. So, without further ado, I'll hand it over to Dugald to speak more about the Ottawa Integrative Cancer Centre.
Thanks so much for the introduction, for the opportunity to speak to the group today. It's really it's a pleasure to talk about the OICC. I feel like a bit of an evangelist for complementary and integrative medicine, as I'm sure many people on this this call are as well and interested. So I've got quite a few slides that I'll go through. I think they're all relatively informative and interesting, related to sort of the focus of this working group, which is really exploring how integrative clinics develop and how to propagate that. And so I will move through some of these quickly, and my apologies if that's too quick, but I think that it's there's a good amount of material to get through, and hopefully we can get to some time for some questions and discussion. So briefly outline for what I'm going to talk about is establishing the vision and mission for the OICC, with some background related to that, particularly from a feasibility study that we did over the course of 2 years before we opened, which really helped us to get the knowledge and some of the partnerships for that development. And then moving more into implementation, we opened our doors in 2011, and it's been open now for almost, will be 7 years as of this fall. I'm going to speak a little bit about patient management strategies, including models of referral, not so much on the outcomes tracking, if there's not enough time for that, but case management, and then really talk a little bit about some of the lessons that I've learned, that we've learned, in terms of trying to create an integrative medicine clinic focused on cancer care, and some of the things that helped us in that whole process as well. Burden of cancer, I won't go over this. We all know that it's an extremely highly morbid disease in North America. In Canada, it's now the first leading cause of mortality. And so it's a real epidemic that we're dealing with everywhere. I won't belabor the points around defining the terms as well, just to emphasize the fact that we're really moving more towards an integrative model, and that's what we're trying to achieve. It's an integrative model of care, not an alternative model of care, and not even really complementary, although the reality is it's still mostly parallel and complementary care. But our goal is to achieve some measure of integration with conventional care. And to some degree, we've been successful, and in many other ways, we are still striving for that. In terms of cancer, I think there is really a high degree of need for information and good information and guidance to patients when it comes to complementary and integrative medicine, because the internet and sources of information that people are being exposed to is really rife with all kinds of misinformation. So, you know, pick your platform. There's good information and bad, but people are really looking for good guidance. And I think, unfortunately, we're seeing more polarization in some ways. I mean, there's two ways of looking at it. There's more integration in some ways, which is great, but there's also more polarity in terms of what people are being provided with information about, especially when it comes to trusting conventional care or not. Some of the consequences of this misinformation is that patients may be refusing curative therapies. They believe that it's possibly harmful, that there are natural cures that are somehow being withheld from them. And there's significant costs that are associated with complementary medicine that patients are incurring. So that's a potential source of harm. There's always the potential for interaction with conventional treatments, although by and large, I think that's an issue that's typically overblown, but I think it's still certainly one to consider with the use of herbal therapies. That avoidance of curative and greatly supportive care is important. And the stress and the anxiety that's provoked by misinformation is huge in the cancer care sphere. Integrative oncology is really a field of medicine that has developed over the last, I would say, 15 years. And there is a society now for integrative oncology that has developed definitions. They have an annual conference. And there is just a very recent publication that came out in the Journal of the National Cancer Institute, which is wonderful, which defines integrative oncology. I won't read through the definition here. The emphasis and underlining, that's my emphasis, but this is just provides, I think, it's a grounding point that we can speak to what integrative oncology is from an academic standpoint. So this is really quite good, and this is an open access publication that you can receive as well. I'm a naturopathic doctor, and there's a really good group within naturopathic medicine, which is called the ONC-ANP, the Oncology Association for Naturopathic Physicians, that is trying to build on integrative oncology as well, and through the Knowledge Naturopathic Oncology website, some of the evidence base for this as well, and we're hoping to work with other groups to try to expand this to make it more universally accessible. So the need for integrative oncology is certainly there. There's a large and growing demand. And that CAM care is still largely unknown to the conventional care providers. So this is something that gives us an opportunity to really reach out and to talk about what can be done for the patients in a safe way that can be integrated. The opportunities are large as far as supporting patients, and we see amazing outcomes in integrative medicine, I feel, every day in terms of our patients' benefits. So improving quality of life, and there's good evidence for this. Symptom management, extension of life is a questionable one. I think there's some evidence to demonstrate that that is possible. We need a lot more, but it's often really what patients are coming to the table for, of course. I think assisting in the decision-making process is huge, providing therapies that can be integrated well, and to improve the patient's ability to tolerate therapy, conventional care is important in all of this. And really empowerment is one of the things that we offer to our patients, and that we engage them in their own process of health. So I'm going to go through just some of the slides for this feasibility study that we did in terms of developing the center. Really there's two components, well, three, but I'll look at the first two. One is the systematic review of literature that we did, looking at international integrative oncology programs that have actually been developed and they published on it. And then the second part was a qualitative study where we interviewed people, patients and practitioners in the Ottawa region to get a sense of what they felt were important for an integrative care center. So the first one is a systematic review. We looked at key areas of publications that spoke to components of care from these centers, their organizational structure and their behavior, how patients flowed through and their families interacted with these centers, and if there was measurable outcomes that were employed. And so this is published. It's also at an open access journal in Current Oncology. We published that in 2012. So the methodology and all that is accessible. I'm just going to touch on some of the results from this. Many of the centers published on were from the United States, the majority, followed by the United Kingdom, Germany, and then 2 from Canada and 1 in Denmark. If you ever see NR, it just means that they were not reported. And so many of these, the majority were in urban centers, 21 are hospital-based, and just talks about the establishment, the date of these as well. Interesting of note here is the types of therapies. So you can see that the vast majority of these had mind-body medicine. then massage, then nutritional counseling, and acupuncture, and then down the line in terms of the frequency with which these components of care were offered at these centers. And I think especially mind, body, and massage and nutrition, perhaps a little less so, these are often considered softer therapies and more accessible and less controversial when it comes to conventional medicine. The organizational structure, you can see some were registered charities, some had boards of directors, many were hospital affiliations, especially those in the United States. Some had academic affiliations, and then quite a few did report on an active research program as well. There are many of these examples, but overall there was poor reporting for a wide range of issues that we did consider. Of course, this was our pre-set series of variables that we wanted to look at, so there's no reason why they would necessarily all report on these, but according to our 88 points of data, there was many of these publications did not report on that, and there's some variation according to the different locations, of course. So that was that. It gave us a bit of a grounding in terms of what was in existence in the literature, and that was helpful just to start the process of really thinking about what this center could be like. The qualitative study was, I would say, more important in terms of our engagement with local people, both practitioners, especially practitioners in the conventional realm, and then also with CAM practitioners and with patients. So we wanted to see what the thoughts and needs, thoughts of these people were in terms of models for collaboration between conventional and complementary providers, how patients should flow through, what the outcomes could be to evaluate the success, and what were some of the possible barriers and facilitators to this. So we interviewed a whole number of people, 39 people in total, many practitioners and many cancer patients as well. You can see the list there and the chart on the right as far as whom we spoke to. And our topics and guides are here. This was done with a qualitative researcher who codified the information in a way, and then we also published this, and that's accessible as well. And we could probably make that publication available. I think it's open access. So just in terms of the results that we found from this process of interviews, we really, the major themes, the major categories of themes were broken down into these 5 groupings. One was model of care, one was physical setup, the third was values inherent, fourth being evaluation, and then the fifth was sort of a catch-all for facilitators and barriers. If I explode the first one, which is models of care, then that broke down into these themes, looking at patient flow and management, how it fits within the existing healthcare structure, how does education follow with this, how does research incorporate within the model of care, what would be the role of the CAM practitioners in this, and what are the role of the conventional practitioners in this. And then the last was the cost, recovery, and payment as an important part. So, and I'm just digging into a few of these, obviously not reviewing all the results, but I think it gives a bit of a sense of a way to structure this information, or the way that we structure the information. So the first subsection of patient flow and management looked at, is there a standard program and consultation for the patients? Is it standardized, or is it much more sort of ad hoc? Is there a primary caregiver that would be associated with that patient? Should there be a coordinator for integrative care? And is there some way of rounding for these patients from an educational standpoint as well, or for the management of their care? Here's one quote from a patient, and really identifies the fact that it's so important that the patient be involved in their care right at the outset. So this is, these are some of the representative quotes from this process. If we look at education, this touches on where is the education coming from, how is evidence incorporated in this, where is the information available as well. If we look at the model of care, the subsection for research, how important this would be to develop evidence for safety, to demonstrate cost effectiveness, to add credibility as an element, and ultimately how would research improve patient care if it's incorporated. A radiation oncologist speaks to the value here of evaluation and how essential that is to the process for credibility. as well as, well, just the fact that it's being done builds credibility, and we've certainly found that to be the case. Here's just some detail, some of the breakdown in terms of the role for the complementary providers. Are they going to be managing side effects? How do they operate supportive care? What about psychological health? How do they identify interactions? How do they help prepare people for conventional care, and what follow-up is required? So these were identified as some of those aspects for the role of the CAM practitioner. I won't read through this, but this really points out the fact that the radiation oncologist or the oncologist, one of the themes that came out is that this concern for the care to be supportive and not so focused on the pathology necessarily, and that this is not being presented as curative treatment for the patients. And that certainly fits with how we approach our care. Last one here is the cost recovery and the payment process. How is reimbursement made in terms of the structure is so important to get buy-in by the practitioners. They need to be well compensated, obviously. How do you do that in an integrative model? And it's been a challenge. What are the patients paying? Are they expected to? Are there programs for those who can't afford it? How can we incorporate volunteer time? How do you work with overlaps in scopes of practice? And this is a really important thing to think about in terms of bringing together the team who serves what purpose for each patient. And we really were focused on not creating competition, if you will. How can we tailor services for cost, and what role can we play in terms of lobbying hospitals, insurance companies, all of which we have really not taken any part of. So here's just two interesting perspectives. Salaried approach from a physiotherapist saying that would be helpful for a patient-centered approach, and then the cancer patient actually interesting of noting that they value the care more if there's some kind of payment associated with that. So that's just that's a snapshot of this publication results, and I think there's a lot more detail there, and you can see it's in supportive cancer care. In 2014 it was published. So moving to the implementation, really took some of this information and the ideas, also having spoken to other people, to with a vision to create a sustainable center dedicated to providing and researching integrative and preventative cancer care that will lead ideally to the creation of other similar centers. And our measures of success would be that we're actually providing this care that has an impact on their quality and quantity of life, and that we're conducting high quality research to test and to demonstrate the benefits of this care as well. These are our end statements, essentially part of the mission. We're looking at a model for whole person care to provide a bridge between complementary and conventional cancer care, to be an evidence-informed resource for patients and for practitioners and caregivers, to do the research. And those four, I'd say, we have achieved some measure of success in those. The fifth one, addressing environmental contributors to cancer, we've really done very little in this, but it's something that our patients are very interested in. We're trying to move more on that. And then the training and education in integrative oncology, I think we've done, with certain groups and with people on a one-by-one basis, and we have a lot of preceptors come through here for students, at least from the Naturopathic College at CCNM in Toronto, and then we make this available for others in the community as well. The pillars of care at the OICC is focused on nutrition, movement and exercise, the mind, body, and spirit or emotional well-being. That healthy environment piece is one that is still a goal. And then healthy physiology, which really looks at the physiology of the individual. How can we augment the physiology in a way to support them to deal with cancer? So be it the immune system, inflammation, there's a variety of ways. And then this is all alongside conventional treatment. So our patient care and our setting is, we want to create an optimal healing environment, and it's clinical, but it's not hospital. And this is also identified in that qualitative review that patients didn't want a hospital-based center. They wanted this actually community-based, which was interesting, which fit with what we were going to be able to achieve anyways. they didn't want that association, especially with cancer, with the chemotherapy ward and all that. We have a multidisciplinary team to meet different needs that are credentialed and experienced in cancer care. They all have clearly defined roles and scopes of practice where there is some overlap in certain cases for sure, but at least it's well defined. We've really taken an approach that's non-hierarchical. There are staff positions, there is a hierarchy, but as far as, you know, our clinical care, patients at the center of the decisions, and we have a very collegial approach. And I think it's really important in terms of building that team that, you know, one type of therapist is not valued over another. And I think, you know, coming from a naturopathic model, that maybe lends itself a little bit more easily to that, but every profession, I think, is susceptible to that perception of more importance from wherever their perspective is. Integrative is another aspect where we have regular communication between practitioners. We have a process where we have open access for patient files between each other, so we have shared electronic medical records. Initially we used paper-based, but we've shifted to a shared model of EMR, which has been fantastic, not without challenges, but has been very, very good overall. Our key components of care are that we're providing individualized care. It's not standardized, but there is some standards, I guess. We do have a proportion of free care for those who cannot afford it, and this has been very, very helpful. We are not for profit. We've got a percentage coverage based on needs. People apply for this, and we'll give anywhere from 10 to upwards to 60% of coverage, and that's for anything. It doesn't matter, whatever they want to make use of. We'll provide that as long as they meet that sort of criteria. Still needs to go further, but it helps us a lot. The integration with local hospitals through educational opportunities being there, and through our electronic medical records, we actually have access to the hospital records, which has been very helpful for us to know what's happening for the patient. We also have a care coordinator, and I'll talk about that a little bit more. That is the patient's point person, and that's, we can talk more about that. And then we also have an active and collaborative research program as part of the center. So patients flow through the OICC. Referrals come from anywhere. There's no requirement for referral. They often hear about us through the internet. That's a very frequent way in which they find out about us. Maybe 50% even, at least at the beginning of our patients, found us on the internet. So having a good website that represented us well was really important. That investment was hugely valuable at the beginning, and still is. But definitely referrals from patients and caregivers and family members is more important now, I would say. We give talks. That's important to dispel some of the myths around complementary medicine. And we get referrals from MDs that are not focused on cancer care, which is great, and other camp practitioners. We get referrals from GPs, general practitioners, family medicine docs. And we are actually getting some referrals even from oncologists and surgeons. That's not the majority of the time. That's a small minority of cases, but it's very encouraging when we get referrals from this group. And we're seeing that. We have seen that grow over time. Hospital staff and nurses do refer to us as well. So patients would call in reception. They would then be typically referred to see a naturopathic doctor. Most are coming to see an MD. But they would also be referred to see one of the care coordinators, which is a non-charged service. And then they might be referred directly to one of the group programs as well. And then the care coordinator will also help, as well as the MD typically, in terms of screening for eligibility for any of the research studies that we have ongoing. So the role of the care coordinator is a very interesting one, and I'm not sure if it's absolutely the right thing. We're still, after 7 years, we've evolved this, we've changed this, and we're continuing to change this. So I don't think there is the right approach, but it's been very helpful to help to ground the patients in terms of the care, offer them opportunities, hear them out, hold their hands, figuratively, and help give them some guidance in terms of the care here. The fact that it's not funded, there's no cost for the patients, it means it's hard to sustain, and that's a difficulty. So that's been an issue around that. But but it has been helpful for the patients. I think it was really helpful at the beginning, and they sort of were a rallying point for the practitioners and for the patients. But now that the practitioners know each other so well, it's less of an issue, to be honest. So the individual services that we offer here, naturopathic medicine, we have 3 NDs practicing. We have 1 medical doctor and we have 2 nurses, which offers us and the patients some additional therapies, which is great. We have a very busy acupuncturist who will see anywhere from 20 even to 30 patients in a day, and he has his assistant to help him out in that. We have a massage therapist and a physiotherapist, which are not full-time, but they really offer some good additional support, especially around the needs for cancer patients. And then we have different mind-body medicine therapies. We have a hypnotherapist, we have someone who does conscious living coaching, and then we have a yoga therapist that will actually do one-on-one yoga, and it's more, in some ways, counseling and mindfulness therapy than yoga per se. And then we have a psychiatrist and a psychotherapist that really helps to support our patients as well. And I'm going to talk a little bit more about the frequency of visits with these services, which I think is really interesting in a little bit. I won't go on about the 2 programs that we have. Well, we have more than 2 programs, but the programs are great because they offer more group care at a much lower cost, and that's been really helpful. And the Head Start program has been wonderful. It's just for women newly diagnosed with breast cancer. To give you a sense, we have 60%, or no, maybe not 60, but a large proportion of our patients are having breast cancer, so it's really nice to be able to target this group with this therapy. But we have a lot of other programs that we offer, which is helpful. Communications is one thing that was emphasized that you're interested in looking at. I think it's a challenge. It's such a challenge, especially with different practitioners in a multidisciplinary team where you're trying to get internal collaboration. And we have, to some degree, with the electronic medical records. And you're also looking at privacy, so you can't just send an email about some patient to another practitioner. It's got to be a secure platform for communication as well. So we have an internal system of emails, if you will, through our EMR system. It's not perfect because it doesn't actually even chart for that patient, but it at least gives a platform for secure communication, and that's really helped us to communicate quickly with a larger group of people about a particular patient. So if you're looking at a system, software, or anything like that, this is a really useful thing to consider. Is what communication platform does it allow? And I think communication also with the patients is important for this too, although not all practitioners they don't all want two-way communication. So that's many of the EMR just simply don't offer that, and ours doesn't. We have practitioner meetings twice a month. It's hard to bring everything together, but that's been helpful. And then we have just informal meetings in the hallway, where we talk about a patient we refer. That's really still very useful. Referrals are happening internally through the care coordinators, but more directly just from the practitioners, and then from outside sources, they can directly refer to any practitioner as well. So just, I think this is interesting in terms of the PR and the outreach, because your model has to be successful to, be sustainable. Obviously, it's got to be able to bring in the people and to build awareness. And we still hear many people in the Ottawa region that they haven't heard about us. So you can think that your awareness is great, but there's always obviously way more to do on this front. So we've done a lot of work. I won't go through this, but this slide is there to give you some sense of the ways in which we've helped to build awareness in the community. Finding real ambassadors that are outside the center has been a really important part of that too. We're using more digital and social media, and I think that's a really useful platform. It's a way of growing that, and I think the content is fire. Social media is gasoline. Is a good one. If you want to be able to provide something that your patients have value, so don't think to sell to them. Think what is going to be of use to them, and then they will become more loyal, and they'll come to you because they know that you're a good source of information. Okay, so I'll talk a little bit more about now our patients, and I think this is interesting. It'll give you a sense of the scope of the kinds of people that we see. Less than 5% still come to us for primary prevention. We've seen that grow a little bit, but it's still a low minority. People are only motivated for care in cancer when they have the diagnosis. And then we see a sort of division in terms of when they'll see us based, whether it's at diagnosis, whether it's during active therapy, or when they've been discharged from the hospital and they're sort of floating and they don't know what to do. And we're also seeing more patients now who are seeing us as a last resort with highly advanced cancers, that there's no real options for them to continue with conventionally. And then we're seeing a small group for us as a true alternative, probably around 5%. And that's a really tough discussion that we have with them, and we try to guide them as best we can in terms of what makes sense and what doesn't. And I think we'd probably see more if we were seeing more as an alternative care center, but probably many don't come to us because of the fact that they probably see us as integrative. I don't know. I can't say for sure on that. So people come to see us for support management of symptoms. They'll come to do everything they can to slow the progression of the disease and to prevent recurrence. Really, many are coming to cure their cancer. They want to get rid of their cancer, of course. And some as a last resort, and some as a complete alternative. And some just come because they were guided here by their spouse or their child or their parent. Critical points for patient contact is right at diagnosis, during their conventional care, or in the sort of post-recovery phase, if you will, or after they've gone through intensive care at the hospital. So the first stage, much more shock, is you're dealing with a lot of anxiety. There's a lot of psychosocial support required and a lot of information gathering. But we can really provide them with a good basis for this. We have the time to spend with them to explore their diagnosis, what the treatment options that they may be facing, give them a sense of the course of the disease even and the course of their treatment. Not that we're going to be telling them which chemotherapy that they should do or anything like that, but we can at least give them some support to understand better. And that's one of the things that's lacking at the hospital is the time with their physicians to really ask the questions that they may want to ask and to have a discussion. So that's really important part of what we do. So here's a little data. And this is old data, but it's I'd say still very much relevant, and it's the best data that we have, so that's what I'll present. This is over a 20-month period of time that we have from our previous electronic health record data. This comprised roughly 1,200 unique patients over this period of time. So you can see that 2/3 are roughly female, and then the ages, we've got a wide distribution of ages. We do see pediatric cases, but it's still a very small group, thankfully, in many ways. It's a really tough group to see, very time-consuming, but there's a lot of support that can be provided there. We see, but it's basically similar to the demographics that you'd see as far as the cancer population in general. The characteristics of the patients are a third, in fact, that have breast cancer, and from this group, that makes sense. And then you can see sort of a wide distribution of different types: colorectal, gynecological, prostate, blood cancers, actually quite a high proportion there, etc. And then the stages of those that we know, right, we know them, but in terms of at the time whether the information is captured, we're seeing a large proportion that are actually late stage, stage 3 and 4, and that's interesting. I think we've seen a shift to earlier stages overall, but this is a good reflection of those patients. Now, if we look at the individual services used by unique patients, and this is the N is just under 1,200, you can look at any individual service, so that's the total count. Those that actually are seeing a naturopathic doctor is just over 1,000. So, over 80% of this population are seeing NDs. 270 are seeing acupuncture, which is really, a high proportion of our patients are seeing the acupuncturist. Then quite a small minority seeing those for mental health, and it's interesting, they don't necessarily attribute as much value as we think they should perhaps to mental health, but they reserve their resources and their payments for things like the naturopathic medicine and the acupuncture, and they don't necessarily provide as much, I guess, importance to this. We really try to emphasize this, and we've actually created a fund to support mental health specifically. A mind-body medicine a little bit higher, and then the physical therapies like physio and massage therapy higher, and then integrative medical care where they actually see our MD and the nurses, well, the MD or the psychiatrist are higher, and then a very small minority, again, well under 10%, that are doing IV therapies. So that gives you a sense of who the patients are seeing as far as care. Now, if you look at the intensity of care, I find this really interesting. This smaller number here, the 3,000 of, again, remember there's 1,200 patients, they're seeing the total number of visits over that time period is 3,000. So the average mean value is 3 times each patient saw that patient. Now there's a huge range. Some patients only come in for that initial appointment, and then some will actually have seen their ND over that 20-month period maybe 10 times. So there's a big range. But this is actually not so, it's a good reflection of the kinds of care as far as the intensity of visits. So maybe it'd be 3 or 4 or 5 would be the ideal number of visits over a 20-month period for the ND. Acupuncturist, far higher. It's much more intense as far as the therapy. So more visits, in fact, for that one acupuncturist over that period of time with 13 visits per patient, though. So lower number of patients, but much higher intensity. Mental health, those that are using it at a higher intensity. Mind-body, lower, interesting. And physical therapies, similar to the ND care. Integrative medicine, much less, in fact. And then the IV therapy, we see even higher intensity. So those that are using the intravenous therapies, like vitamin C, or like mistletoe, like DCA possibly, but IV vitamin C, we could talk at length about that, but we won't now, higher intensity for those that are using it. So this just gives the average number of appointments for patients, their mean, and the range. So, you know, one practitioner, for example, saw 11 practitioners. One patient saw 11 practitioners and 229. So it just gives you a sense of that scope, that range. Here, the different practitioners you can see. So the count over 600 are seeing only one practitioner, whereas 280 are seeing 2 practitioners, etc. down the line, right? So not surprising. The majority are seeing 1, 2, possibly 3 practitioners. Okay, so just going to look at some of the lessons learned in this and end on that. So I think some of the challenges have been the integration, both internally and externally, and that is an ongoing process. Trying to implement a model of care that everyone buys into, both patients, the practitioners at the hospital, our own practitioners, has been a challenge. I think we're trying to walk a relatively thin line in terms of providing alternative and complementary medicine that is, really supportive of the patients, but is also evidence-informed, and we can defend to our colleagues at the hospital. So that's, and we're in a very, I think we're in a place that we feel relatively comfortable with them, but we're always examining that. The physical and software infrastructure needs are a challenge for sure. The funding is always a challenge, and we've been successful and fortunate to get philanthropic support. But ultimately, I think that is not going to sustain it. It needs to be able to stand on its own as a business. And I think in many ways, actually, there's more challenges in Canada to achieve that, where people aren't used to paying for care. And really getting the right team in place is essential. You do not want people that are really lone practitioners. So we've had resources from the Canadian College of Naturopathic Medicine, very much so at the beginning especially, and provide infrastructure support. The patients of the cancer patients and their survivors and family members have been resources for sure. We've had foundational funding. We've had our practitioners and researchers, and then there's a good aligned organizations, and I think it would include the ACIH in this, but ONC-ANP certainly for the naturopathic profession. It's the Oncology Association of Naturopathic Physicians and the Society for Integrative Oncology. And then community leaders, both physician but also business leaders and people that see the value of this. They've been real ambassadors in advocates, and that's been wonderful. The importance of collaboration and integration internally is essential. We talked a lot about that. Getting consistency, meeting the patient's needs, having effective follow-up for these patients. And then externally with the hospitals and with other practitioners. It's not perfect by any stretch. Us accessing their hospital files has been really helpful. Using consultation and progress notes to convey what we're doing to physicians at the hospital has been a way of building understanding and building trust that we're part of the healthcare system and that we're not just total outsiders, and that's important. Referrals and supporting recommendations for others, and then providing opportunities for education, giving talks, being transparent, being open, and having people come in. So in terms of barriers, I mentioned the lone wolves. Practitioners that do not do well in team environment can be fantastic practitioners, but may not necessarily lend itself to an integrated model of care very well. That sense of hierarchy is important to, I think, always orient the patient's needs first, and then everyone can gather around that idea. Where there's unwillingness to communicate and cooperate, you've got to address that at the beginning. Is much easier as well. Lack of communication, always just the time of that. Resistance to change exists internally as it does externally, and the time mentioned. Our facilitators internally have been the care coordinators, have been shared patient files, have been this interprofessional communication that we've had through various means. And externally, so this is not within the clinic, but externally with the partners in the community, resistance to change certainly is one, and I think that we all know this from conventional care, that there are biases, there's perceptions, there's myths about complementary and alternative medicine, some of which are true and some of them aren't. And so, I think establishing locally what your center is doing and building those relationships is essential for this, to break those down. It's much better for having other people speak on your behalf than you speaking on your behalf in many cases. The patient's lack of self-perception of power is another barrier. Patients still feel very much a recipient of care from not a participant in care. And I think that's one of the things that many of our patients already have. When they come to us, they're already sort of somewhat empowered because they're adopting integrative medicine. But too often it happens that, and I think we're not seeing those others, but we're still encountering, it's like, well, my dietitian told me not to do this, or my oncologist told me not to do this. And like, as long as we can address that, but I think trying to build on the patient's sense of empowerment is important. Our lack of a strong base of evidence, to really ground our integrative medicine is certainly a barrier. There's no question. So we need more research. And the cost as well is a barrier. And I think that's even more so important in Canada than in the U.S., but I know I'm sure it applies there when there's no insurance, of course. So our external facilitators have been champions in the hospital and the community. We have had some. That education and outreach, the communication, the partnerships, not-for-profit status, the research that we're doing, we can talk about that, but that's really been helpful. And vocal and empowered patients are really amazingly powerful. They are. So some of the last lessons are relationship building that we've been able to do, our ability to evolve and to adapt, supporting other people's initiatives, being part of a collaborative network, being open, transparent, being proud and strong in support of integrative medicine. Don't apologize for it. This is totally where it's at. Having a persistent positive outlook, enabling research, finding local champions, and being involved in communication, education, and collaboration. So that's it for me. Thank you so much.
All right. Thanks so much, Dugald. That was an incredibly informative presentation, and there's so much information in there. and so much to learn from it. And all you've done with the clinic to date and the research that's behind it, I think is going to be a great benefit to other integrative clinics opening up, both in cancer care and otherwise. So we've got 8 minutes left on the call, and I will open it up to questions from those that are listening.
Great. Yeah, thank you so much, Dugald and Mitchell. I will monitor the chat, so if you have something you want to put in the chat box for all, and I'll also look to see if there's any hands raised. None yet. People are probably digesting. Dugald, is it all right to share these slides along with the recording?
Yeah, that's totally fine. Especially if it can be done in the PDF, I think that'd be great.
I can put it in a PDF, sure. Okay.
I would just ask people not to distribute it.
I'll put a note in.
So maybe I'll ask a question while we're waiting for others to come up. You talked a lot about your challenges, your major challenges. I'm wondering, just what you think about how the integration has worked successfully at the OICC. Looking at your statistics that you had, you're seeing patients seeing 1 or 2 practitioners on average, and most of those are the NDs. So do you feel like your other services are being utilized to their most? How do you think that they might or might not be, and what would you do to change that utilization?
Yeah, it's a great question. We struggle with this a lot because we've got our associates. They are here in the practice, and they're fee for service. They're getting compensated by the patients that they see. They obviously want to be busier, and they also want to contribute. And so there's the challenge, though, for the patient's perspective is like, how much can they take on as far as care? Like, I think everyone would benefit from seeing massage therapy, reflexology, counseling, naturopathic medicine, you name it, right?
Yeah.
But so it's trying to really get a sense of from the patient's perspective what their needs are, how much time and desire do they have for additional care, and then sort of referring them accordingly. There's always a discussion. Well, I think with my patients, I talk to them about the need to, how is their local support, and how are they really coping with this? And there's always sorts of like the underlying question. And if I feel like there's a lot of anxiety and I'm not the best served to help them with that, and that's often the case, then I try to really encourage some form of counseling, and maybe it's counseling with their own resources. So it's not just our own practitioners that we're making use of, but it's also the resources that the patients may already have that they can make use of. And so it's the care coordinator does take a role in that, and I think that's nice too, because the patients see that the care coordinator is not, they're not, I don't know, they're not paying for them. They see them as someone that they can just offer that support. Yeah.
Right.
Mitchell, we have we have a couple of questions coming up and a hand raised, so is it all right if I jump in and read some of the questions?
Please do.
In the chat? Okay, great. What level of training in cancer, standard treatments, and side effects is required for the practitioners who may not have received it in their initial education?
It really depends, I think, on the practitioner. I mean, with the NDs, we're pretty careful with that because there's such an emphasis on this type of practice, and they're typically recommending things like, herbs and other biologically based medicines. So they need to know, they need to have some additional knowledge in this, and we can evaluate that for our own. So ONC-ANP, at least membership and a track record of having cared for cancer patients. I think I'm getting some echo, but then for the mental health practitioners that they have experience for this, I mean, they can there's no requirement from their regulatory body that they have additional training to provide that care, but it's really that they have some experience in this area. So we do a lot of evaluation based on that. For the massage therapists who do things like who might have lymphedema training or drainage therapy or wrapping for lymphedema, for the physio, then they do require sort of having met some additional training for that if they're going to be providing those therapies. So it's, you know, it's relying to some degree on the practitioner that they have their credentials to practice in the jurisdiction that they are here in Ontario, and that there is a, you know, there's an interview process in terms of their ability to manage cancer patients.
Thank you, Dugald. We're at the hour. Is it possible for you to stay on a little bit longer and answer some questions for those who can?
Yeah.
Okay.
Yeah, for sure. I'm okay to stay on for a bit.
Fantastic, yeah. Fantastic. Another question, how does the center determine the necessary qualifications necessary for integrative providers? Is there a standard criteria for each domain, and how is provider scope addressed and assessed?
So I think the first part I sort of addressed with the last question in terms of credentialing. They need to basically have their own insurance, and they have to be registered within their own profession, if that profession is a regulated health profession. So as far as scope goes, you know, the process of taking someone else on into the clinic, there is a discussion with any of the other practitioners who may have a cross scope with that practitioner. So, you know, we had 2 acupuncturists, for example, and before bringing on the second one, we had a discussion with the first about the, you know, like there's more needs that were there, and just assessing for the comfort level of that practitioner before bringing that person on. So it's really a discussion in terms of whom we bring on where there is scope overlap. And most of these therapies, there's not a huge amount of overlap. I think the acupuncturist and the naturopathic medicine one would be the most. And for us, the NDs, where acupuncture is part of our scope here in Ontario, we actually feel happier relying on someone who has had more extensive training in this, although one of our NDs still does acupuncture for things that she feels that it will help, but it's not a conflict. So I guess yeah, long answer, but we really assess for potential conflicts that are going to come up between practitioners because of it, and try to address that before making a unilateral move to bring someone on.
Well, thank you. Here's a question about seeing patients who lack confidence in talking with healthcare providers about CAM use. What are some strategies that you're using to change patients' lack of self-perception of power?
That's a great question. I don't think we've codified that at all. But I think that it's giving them the space in part to ask the questions, and proposing that they may, you know, bring forward some questions to their healthcare provider as well. We always advocate for transparency of care so that there's you know, what the patient is doing with us from a complementary perspective is told to the provider, but there's always that concern that there's going to be, you know, restrictions placed on it, or some level of, I guess, you know, discrediting or some kind of judgment that they're going to receive. So I think preparing them for that possibility, while not necessarily expecting it to be the case, is something that what I'll do, and that's often helpful, and just to give them, you know, a sense of that they are saying that, you know, they are the deciders of their own care. It's like, you know, and just reinforcing that for them. So it's you know, it's really them that have to make that shift, but it's opening up the conversation. This is definitely something to be considered.
Nice, thank you. Given the range of providers at your clinic, what services do the integrative MDs provide?
So it's interesting. The integrative MDs, psychiatrist is basically non-pharmacological psychiatry, although she'll advise patients on drugs if need be. But it's more talk therapy, and that's helpful, and it's covered by the Ontario Health Insurance Plan, so there's no cost for the patient for that. So that's, of course, mental health. And then the other medical provider, the physician, is giving certain off-label drugs that have some evidence for use in cancer care, things like the use of metformin, as an example, that they might provide. Also gives them, in many cases, our patients don't have their own family practitioner, so this gives them some way to manage some of their other comorbidities, looking at, just say TSH levels, things like that. The NDs can help with management of that, but we don't have the same scope, at least here in Ontario, for management. And then the other part is the use of the intravenous therapies, where the nurses cannot take delegation from a naturopathic doctor currently, so they can from an MD. So this allows us to have a nursing team to provide some of the IV therapies our IV therapies, intravenous therapies, under the management and direction of the medical doctor.
Very helpful, thank you. And here's our last question. If you have an opinion about this, what is it? The approach of the Cancer Treatment Centre of America, if you're familiar with that, in comparison to your clinic in Ottawa. The Cancer Treatment Centre of America has an integrative care model.
Yeah, I know them well, relatively well, from just having visited them a few times, but they are far larger in scope from what we're achieving. They're hospitals. They have thousands of inpatients, I think. It's a totally different scope, and they truly integrate conventional care, chemotherapy, radiation, the targeted therapies. They are a hospital center for care with some of the integrative modalities. They've done that, and there's been a real sort of inclusion of naturopathic medicine in the model of care. They actually did a lot of training for residencies for NDs, which I think built a cohort of well-trained naturopathic doctors in oncology. Unfortunately, that's actually not happening anymore, the residencies, but there's still the inclusion of complementary medicine. It's an integrated model, so it's great. I think they've done a lot in terms of that. We're a community clinic. We're a far smaller in scope. I think we punch above our weight class in terms of our size, but we're a totally different beast to the CTCA.
Well, this has been fantastic. Many comments have come up in the chat box, thanking you very much and showing appreciation for this presentation today. So I'd like to thank everybody for coming on. Dr. Seely, thank you so much for your preparation and for talking with us today. And Mitchell, thank you for the introduction and for moderating.